Modern Dental Assisting, Chapter 45, Dental Cements. So uses for dental cements include as a cavity liner for pulp protection. We can use them as a base. Cements can be used for insulation, pulp capping, a pulpectomy, temporary restorations. We can use them for temporary cementation of proximal coverage, permanent cementation for fixed restoration, root canal sealing, or for resin bonding. We'll talk about the classifications of dental cements. So we can classify these into 3 types according to their properties and intended use. We have type 1, these are eluting agents, which include permanent and or temporary cements. Our type 2 include our restorative materials such as glass ionomers. And then we have our type 3, these are our bonding agents, liners, or bases that are placed within the cavity preparation. We'll talk first about our permanent cements. So these are used for our long-term cementation of cast restorations, like our inlays, our crowns, bridges, veneers, and then ortho. Once prepared in the laboratory, the cast restoration is going to be delivered to the dentist for cementation. We'll use eluting agents and must have the qualities that don't interfere with a proper fit. For our temporary cements, we're going to use these to temporarily cement an indirect restoration. We're going to use these when the dentist needs to remove the restoration at a later date if the tooth is sensitive or exhibiting other symptoms that might require removal of the cast restoration, and then when we have provisional coverage. Variables affecting final cementation might be a number of factors. They could include improper mixing technique and time, humidity, and incorrect temperature of the glass slab. For mixing time, we're going to follow the manufacturer's directions regarding a material's exact mixing time, working time, and then also delivery time. Any delay between completion of the mix and setting of the cast restoration will result in the initial setting process, which could cause the casting not to seat properly. So guidelines for mixing dental cements include, before mixing, we're going to follow the manufacturer's directions to determine the use of cement and then measure out the powder and liquid according to those directions. We'll mix on treated paper pad, glass, or on our Teflon slab. We'll keep the powder and liquid separate until we're ready to start that mix. We're also going to divide our powder into increments if that is recommended in the instructions, and we'll incorporate each powder increment into the liquid, and we're going to mix thoroughly. With humidity, premature exposure to warm temperatures or humidity can result in a loss of water from the liquid or an addition of moisture to the powder. So we're always going to dispense the powder first, then the liquid to minimize the loss of water. We'll wait until it's time to mix the material before placing it on the pad, and we're not going to set it out at the beginning to sit while we're doing the procedure. Powder to liquid ratio. So when we're incorporating too much or too little powder, this is going to alter the consistency of the cement. We want to always fluff our powder in the bottle before we dispense. And we're always going to use the measuring scoop if it comes with one. We'll hold the bottle in a vital upright to ensure that the drops are consistent size when dispensing our liquid. With temperature, specific types of material have a chemical reaction during the setting stage. Zinc phosphate cement, in particular, generates heat. It may be beneficial to use a cool glass slab in the refrigerator or pull it from the refrigerator before we're mixing the cement. We want to make sure that we thoroughly wipe our slab dry before dispensing the material so as to we don't want to incorporate any moisture condensation into our material. Selection of cement for a specific procedure requires knowledge of the chemical and physical properties of each particular type of cement. So we have our glass ionomer, composite, zinc oxide eugenol, polycarboxylate, and then our zinc phosphate. Our glass ionomer is very versatile. It's supplied in special formulations according to our use. So we have our type 1, 2, 3, 4, 5, and 6. Advantages of glass ionomer, it releases fluoride slowly, so this aids in inhibiting recurrent decay. It causes less trauma or shock to the pulp. It has a low solubility in the mouth. It adheres to slightly moist tooth surface. It has a very thin film thickness, so this is good for seating castings, and it can be formulated for the use as a dentin substitute or base material. Chemical makeup and application of glass ionomer cement. So the chemical makeup is a liquid and a powder, a polyacrylic acid, copolymer, and water, and then the powder is calcium fluoroalumosilicate glass with barium glass. The application is self or light cured. It's supplied in bottles of powder and liquid, which can be mixed manually on a paper pad or a cool, dry glass slab. This is also supplied in pre-measured capsules that we would triturate and then express through a dispenser. We have the option of resin modified glass ionomer cement. So this is a hybrid product. It has high strength, a longer working time, less sensitive to wear contamination. The benefits include little to no postoperative sensitivity, forms strong bond to enamel and both dentin. Its coefficient expansion is very similar to that of tooth structure. We have a longer working time with this material. It releases fluoride and it's easy to use. The chemical makeup includes our liquid and our powder application. It's available in both light curing and auto mix syringes, and then a liquid powder formula. For our resin-based cement, this is a new classification of cement material, and we use this for cementation of ceramic or porcelain inlays, onlays, crowns, and bridges, ceramic veneers, ortho, and direct bonding of ortho brackets. The chemical makeup includes resins, inorganic fillers, and organic silanes. This similar physical properties to our composite resins. With application, the tooth must be free of all plaque and debris. It must be prepped by etching or by treatment with a bonding system before we cement. Powder to liquid mix, or we can use a syringe type applicator, or we also have a light cured or dual cured system. Our ZOE, or zinc oxide eugenol, has a soothing effect on the pulp, so often used on patients when postoperative sensitivity is a concern. Type 1 lacks the strength and long-term durability and is used for temporary cementation or provisional coverage. And then 2 has reinforcing agents that are added, so we can use this for our permanent cement of our cast or appliances. Type 3 is indicated as a thermal base. This is used for placement of a temporary restoration, prepared and placed in the cavity preparation. 4 then we can use as a liner. This comes in liquid and powder. So the liquid is a eugenol, water, acetic acid, and then the powder is zinc oxide, magnesium, and silica. We're going to mix on an oil-resistant paper pad that won't absorb any of that liquid. When a slower set is required, we can use a glass slab to help slow that time down. The thickness of the mix is going to be determined by the powder to liquid ratio, and we'll just follow the manufacturer's instructions. Polycarboxylate cement is generally used as a permanent cement for cast restorations, stainless steel crowns, or ortho bands. It maintains its versatility as a non-irritating base under composite and amalgam, and also as an intermediate restoration. So this is provided as a liquid and a powder. The liquid may be measured using a plastic squeeze bottle or a syringe type. The liquid has a limited shelf life because it thickens as the water evaporates. Mixing is carried out on a non-absorbent paper pad. If it's necessary to increase the working time, we can use that glass slab. We have zinc phosphate. This is reliable. It's classified in two types. We have our type 1 and 2. One is used for permanent cementation of cast restorations like our crowns, inlays, onlays, and bridges. 2 is recommended for use as the insulating base for deep cavity preparations. Chemical makeup is liquid and powder, being phosphoric acid and water with aluminum phosphate and zinc salts. And then we have zinc oxide and magnesium. The powder is divided into increments of varying sizes, with each increment spatulated before the next is added. The powder must be added to the liquid in small increments. And then for cement removal, once the dentist has completed the cementation procedure of an indirect restoration, the patient is going to be asked to bite down for a few minutes on a cotton roll. We're going to let that setting process start. The excess cement is going to be removed from around the margins, interproximal spaces, and adjacent areas covered with excess cement. If this cement isn't removed, it could irritate the area and also cause inflammation and discomfort for our patients.